Welcome to this first presentation or case presentation on behalf of the Implant Aesthetic Academy. We're super excited to be going live Facebook and to really reconnect with all of our existing Implant Aesthetic Academy members, dentists who have done many courses of ours over the years. And really looking forward to reconnect or connecting with a whole bunch more that over a period of time we would hope to see you and share our experiences in implant and restorative dentistry. So today we are going to talk about injection molding, and I think it's a really relevant topic for a number of reasons which we'll get involved with a little bit later on. And I'd like to welcome my partner in crime for the next hour, Dr. Jean van Lierop. Jean and I have been involved in many projects over the years. We obviously both, if you didn't know, practiced in Cape Town, general dentists, restorative dentists. And I think I can speak on behalf of Jean, really looking back to doing what we love, which is really, working in our practices. So the first thing I would just like you all to do is take that down, take a screenshot with your camera, whatever it is. That's our Facebook, Instagram, and website for the Implant Academy. And as I say, over the next few weeks, we're going to be hosting some really cool cases, and you can stay connected with us through these three platforms. So, Jean, I take it you're there, yes?
Morning. How's it? Good
go.
afternoon. I'm here.
Okay,
I'm alive and I'm listening, and thank you for the invitation. I'm looking forward to spending some time with you this afternoon. It's a great case you've prepared for us. Very interesting. A lot of different little tips and tricks that we can really get into. And I'm excited to actually start talking about teeth again. I'm a bit tired of talking about viruses and pandemics and helping my kids make cakes. I'm a bit over that.
Exactly. Yeah, exactly. And we will be back in our practice. We will be back in our practices. And yeah, we need protocols. We need new stuff. And really, this is exciting, I think, for restorative dentistry. And we're going to go through the whole process of wire injection molding. Initially, I thought I would put a slide in kind of saying why we shouldn't do it freehand and why we should do it in injection molding. But then I thought, let's focus on the injection molding technique and really put an argument forward as to why maybe injection molding is a better way than the traditional way, which was building up teeth, and certainly in a case like this, building them up freehand. And I kind of like it to the indirect ceramic way, where we've moved, certainly in my practice, from doing things in an analog way, and we all know that word, to digital. And I thought actually really what we're doing is not only taking all the techniques, and we'll go into the planning and everything, but we're taking direct restorations from an analog way and providing the treatment exactly as we would in a digital way in indirect ceramic restoration. So I kind of call them really, it's a digital direct method, or in DSD, we call it DSD direct. So that was just an interesting take on that. But why injection molding? These are really important aspects, I think, in dentistry in 2020. So first and foremost is being conservative. We need to preserve tooth structure. I think that dentistry has got to a point where every bit of it really, certainly if it affects the front of the mouth, needs to be facially driven. Gone are the days where we can fix teeth without understanding what is the aesthetic outcome of that particular treatment. Of course, I've touched a little bit on the benefits of planning cases digitally. And as I say, that applies, in my opinion, both direct and indirect. Maybe the most important point is clinical control. If I think back to analog dentistry, it was so difficult, certainly when it came to, oh my God, someone's writing on my screen, but anyway, when it came to, and ignore that little red line, when it came to
Somebody's hacked
control,
your computer, bud.
I think there's a virus. Did I say virus? We have a virus on my computer. It's getting rid of some of my slides. Anyway, let's ignore. Oh, there it's gone. And so, yeah, clinical control is really important, you know, and why I love this case, because if we look back again at analog versus, you know, digital in a restorative method, the fact that we moved to digital allowed really a better quality, in my opinion, of restorations. And so when it comes to freehand building up, certainly in a case like this, I think really we're talking about operator dependent skills, and we know that these vary a lot. Whereas with injection molding, we almost do away with this, you know, kind of unique ability that you have to have this very high skill level to provide the most beautiful restorations. So that's one of the really most important is having the control in the clinical case right from the beginning to the end. And then, of course, you know, this is the sign of the times. I think affordable dentistry, in all honesty, should have been something that we focused on, but I think will be something that we have to focus on going forwards. And then, of course, maintenance. So I don't know if there's anything that you would like to add to
no,
that list,
completely. So for me, obviously, the short list you have here is a big, all the big advantages for doing direct restorative in a case like this. The biggest advantage for the flow that you have is combining is the conversion of the digital plan and the digital design into the actual final result, and how to convey that and how to build that in. So traditionally, personally, I've done a lot of that freehand. So from a wax up, try and copy the wax up as much as you can, and try and work hand in hand with the technician. But it's just clinically very difficult. So if there is a shorter and easier way, after spending all that time in the laboratory trying to get the occlusion right, trying to get the guidance right, if we can just copy that, it makes life so much easier when it comes to the actual implementation long term. It's so much quicker. And that for me is the biggest advantage of combining the connection between the digital world and the analog world through this molding, which is
yeah, for sure. So what we're saying is what we plan is what we get, and the weakness previously when it came to planning, when we planned analog, what we planned analog is not necessarily how we finished the case, and so that was a key thing.
Yeah.
So yeah, and I think that this is a nice term of what we're really trying to do is we need to focus on patient-driven dentistry. You know, not dentistry that's driven by our needs. It's driven by the patient needs. So I really like this phrase of patient-driven dentistry. Maybe it's a new hashtag for our profession. So we've touched on it, and really it is in the planning. And I think that any restorative, any implant case, you know, these days, 2020 needs meticulous planning. And planning is, in my opinion, really super easy. So how do we go about it? Is we initially digitize our patients. And I think this is a standard protocol. What does that mean? We're going to, in the first appointment, generally, we're going to take either photographs or facial scans, intraoral scans. So we're going to create a digital model of that patient. And then depending on the case, it's either going to be digital x-rays, PAs, bite wings, or CBCTs or PANs. So, you know, that will vary from patient to patient. The next process in the sequence of how the case unfolds is and this is how I'm doing every case in my practice, is that we're going to create a 2D plan of the treatment that the patient is requesting. So I know that there are many ways of doing this. I've found, and I've tried many over the years, and I have to say that using the app, the DSD app, is a super simple, super effective way of communicating exactly what it is I want to achieve during the procedure of the case. So from the 2D plan, that then goes to a planning center or a laboratory. So in this case, I used the DSD planning center in Madrid. I sent them the 2D images and the 2D plan. And from there, they formulated a 3D plan of the case. And we'll get into that in a little bit later. And then from the 3D plan, when we're happy with the treatment, in other words, we've carried out completely the virtual treatment on the case. And the way I love it, and it goes with all dentistry, is it allows us to make mistakes virtually before we touch the patient. And from there, once we're happy, we perform the dentistry. So I think that's a standard workflow. Do you agree with me, John?
No, completely. So you have to, the digital workflow is the way to go. And exactly what you do here is what we do as standard for all our patients. So any large case like that, we go through exactly the same protocol, exactly the same phases, and then we can build a treatment plan. It just brings predictability so that everybody knows what a comprehensive consult is, what information we need, and we can plan it, whether it's going to be 6 restorations, 20 restorations, or 5 or 4 or 3. Doesn't matter, it's the same protocol.
So yeah, the interesting thing with planning, I always used to think that planning was a waste, not a waste of time, but took so much time.
No.
But obviously over the years, what I've realized is planning is everything, because once you have the planning, the actual treatment becomes simple and simplified, because really most of it, and certainly in a case like this, we're providing guided dentistry. So it's predictable and yeah, much, much quicker, to be honest with you. And that's the key for this sort of dentistry. But anyway, let's go into the 3D plan a little bit. So just to put you in the picture with this case, it was a post-orthodontic case, and we'll have a look at a couple of different views in a few minutes. But to put you in the picture, it was a post-orthodontic case. The orthodontics had probably been finished about 8 years prior. It was a missing lateral case, as you can maybe see from this slide, where the canines had been moved into the space of the laterals. And that's a great debate on its own, by the way. And then and the spaces had been closed from the back. But let's maybe get on to one of the occlusal slides that will show a little bit of where the space distribution was. But really what we've seen is the benefit of planning in this slide. And what we've seen is an overlay of the intended outcome on top of the existing outcome. Does that make sense? Yeah.
Yeah. So basically, what you've got is the DSD design that you've created within DSD app, and you've overlaid that over your intraoral scan, and then you can see the blue being your design, ideal design, and then the model itself being the darker or the gray background.
Yeah, so this is actually a 3D design. So this is actually, we've gone from the DSD app, which was 2D to 3D. And so we actually see in the 3D design.
And then from here, just for those who are going to have questions, what are the actual measurements that you've got in there?
So, and sorry, I forgot to, but we can mention it now, is that please, that this is an interactive process. So we want questions. Obviously, I can't answer questions right now, but at the end of the presentation, we'll have ample opportunity to answer all the questions. So what we're seeing here is the measurements are measurements for potential gingivectomies. So we've explored where the ideal situation was going to be. And in order to get the absolute ideal situation, it required that we do a number of small gingivectomies on certain teeth. Now, this doesn't mean we do them. We have the opportunity to discuss with the patient, the implications of whether they think it's important. And again, we're going back to, what did we say, a patient-driven dentistry. And so actually in this case, we decided not to do any soft tissue corrections because we didn't feel it was hugely important. And we didn't want to complicate the case. So, I think that always we want the most simple treatment options for our patients that we can. And the only thing that's relevant, and we discussed this, is that you will see on the canine on the left side that there's still a pink area. And what that means is that tooth, that element of the tooth, is sitting facial on the outside of the intended final restorations. So in other words, either we have to prep that, or if it was sitting a long way to the outside, we'd have to move it with orthodontics. Or we have to potentially move the final restoration slightly buccal in other words, become slightly more additive, in other words, in order to prevent having to even prep the tooth. Was that, is that kind of clear about that slide?
No, completely. Yeah. No, it's important because this was the ideal design. So from the ideal design, you have a starting point to have a discussion with the patient, and then the patient can choose what is it that they would prefer and what fits within their planning. So with or without gingiva, with or without orthodontics, and then each and every decision the patient makes has got its consequences, and they need to understand what the implications are of those decisions.
Sure. And don't forget, we're still going to have the opportunity, and in fact, this slide, we don't even show the patient. We're going to have the opportunity to allow the patient to visualize, to live their treatment in the mock-up. We all know mock-ups are an essential part of dentistry going forward. So if we look at the buccal views of the case, we can start to see that there were some space issues. You know, and I think the key element here was that the decision was made not to do orthognathic surgery. In other words, we had to deal with keeping the occlusion where it was. But in order to get the anterior teeth where they needed to be, in other words, facially driven orthodontics, we needed to leave spaces somewhere. And in my opinion, you know, where they left, I wasn't involved in these orthodontic decisions, but where they left those spaces was the best place, because now it becomes an issue of, is it aesthetic? No, leave it alone. That was, I don't know if you want to add anything there.
No, completely. So here we've got the classic scenario where you've got a missing lateral, and the decision was made to move the canine into the lateral position and bring the premolar forward. A lot of time what happens is you get, they try and either close the gap up by bringing the 6 and 5, gap between the 6 and the 5 closer together, but then you start pinching the jaw almost, and you can get restrictions. And then long term, that's a lot less stable. So from orthodontic point of view, once you bring in the occlusion into this, you want to create a scenario where your potential canine, the premolar, the 4, is in the ideal guidance position so that you can use it later. If they chose to close the gap and leave the gap between the 4 and the 5, aesthetically, it's going to be a lot more difficult to work with. And obviously, you can't close the gap. If you close the gap between the 4, 5, and 6, you close the whole thing off, you're pinching the arch, and you're going to get a functional problem, and you can develop functional issues, TMJ issues, and those kind of things. So that's a problem.
Yeah. Or worst case scenario,
what they did was amazing.
Or worst case scenario is bring everything back and then completely destroy the aesthetic outcome of the poor patient.
Exactly.
I've seen that.
No,
I've seen that so many times.
No, exactly. So what they did, the choice that they made was amazing.
So yeah, I mean, I think that what we're saying is, you know, we design always with the face in mind. You know, gone are the days where technicians sit in a lab with a model and put wax on it. You know, when we're deciding where the teeth need to go, we're deciding on these factors with the face in mind. So this is super important. So in this case, it was an aesthetic case. The patient came for me for an aesthetic improvement to correct, obviously, the canine problem and turn those canines into laterals, the premolars into canines, and close gaps. So, you know, what we're seeing here is the number of teeth I felt that needed to be treated, first of all. So we're treating from the second premolar to the second premolar, bearing in mind the laterals are missing. And we're having to really look at where the spaces are. So from an occlusal point of view, when I saw the 3D design, I'm sure that it looked great from a facial point of view, but from the occlusal, I saw problems. And the problems I saw were on the screen left side, that we have an issue with contacts, and you can see the shape of the intended canine and the contact area, the open contact there, which would have trapped food and caused a problem. And remember now, we're going to take this case, because I think that in restorative dentistry, it's the most predictable occlusal scheme, and turn it into a canine guidance case. So the guidance was going to be key for me in order to for the longevity of the anterior restorations. So I don't know if you think you want to add anything there.
No, but so what we've got is the ideal design. We haven't chosen what material to use, but we're looking at the pros and cons of what is actually going to be happening. So you've already mentioned that the contact areas are going to be difficult on the left-hand side, and it's critical that we work towards the best possible canine guidance we can create. In this case, we're looking at converting the premolar into canine guidance. So we have to look at what is the long-term implications for the material choices we make when it comes to converting that. What's going to happen with those canines long-term? What is the best material choice for that? And how can we predictably close the diastemas and have long-term stability? So then you start looking at, okay, ideal case, ideal position. What is the ideal material to use for this kind of scenario?
Yeah, given that we want this case to hold up in the long term, that I think that these are not cases that we're doing with the understanding that that they're going to need constant care and attention. No, not at all. So we want to try and provide the most stable situation going forwards. So I think that when I looked at the case, I realized that maybe the canines, or turning the premolars into canines, is going to be slightly problematic in terms of managing this small diastema, or this small interproximal space that we have between the existing canines and that premolar. And that if I was going to be relying on the new canines, which the premolars, on the entire guidance pattern, that maybe I needed something a little bit better designed and a little bit stronger, that was going to allow me to control the guidance and finishing that area interproximally. That's always my concern, that these things need to be clean, that patients need to be able to clean them. I don't want to leave overhangs. I don't want to leave areas that might break down the line. So when I look, carry on.
No. So I was just looking at what your solution was.
Yeah. So my solution was that and I don't think our hands are always tied. That we have to always consider that we have to either go left or right. We have so many beautiful materials available to us, and that when I sat down and looked at the 3D design, I looked at the aesthetic demands, I looked at the functional demands of the case, and I decided that for me, most likely the best case scenario was to mix the use of ceramic with composite. And here we were going to use an injection molding technique. Why? Because I was doing all the design. I'd done all the design digitally. So why not make use of all that information? It's crazy to do a 3D design and then not use it. So, and we're going to get into how we now utilize all of this 3D information practically in managing the case clinically. So
just for me, the key here is when making the decision is obviously we're looking at long-term stability. And my experience in the past has been that when you look at failure of composite restorations in this kind of work, the two main areas, the first would be the canine. Especially when you're building in canine guidance, you tend to find that the tips of your canine where they guide tend to fracture first. So that's the first area of failure. And then you do get a delamination of your centrals. So that's long-term, where you tend to have to do the most of the work. So in this scenario, you chose to do the ceramics on the canine exactly because of that reason, is because you want to create a long-term stable solution that's going to give you the guidance long-term, and you're not going to end up in a 2-3 years time having to repair and try and rebuild that canine guidance all the time. So this is your long-term stable solution and the best possible thing you can do for the patient in the long run. Completely agree.
Yeah. And bear in mind that obviously building in this occlusal pattern is going to protect your anterior restoration, your incisal restorations, your composite restorations. And without this protection, and we've been there, we've done that, you're going to be repairing things month after month. And there's nothing more frustrating. And there's nothing that impacts negatively our practice economically than, repairing things for free. Yeah. So, this is something that we're trying to avoid all the time. So anyway, If we looked at the ceramic preparation, so bear in mind these two teeth have now actually been prepared, and pretty much this case was dealt with without having to remove any tooth structure, bar this premolar, which we can see I had to smooth the contact area. Why? Because of path of insertion. And so this is really, a big factor when it comes to direct injection molding versus veneers. So once we start to place veneers or ceramic restorations, we have to remind ourselves that we always need a path of insertion. So if we're going, to an injection molded direct, the path of insertion is irrelevant, because the composite is going to flow into the undercuts, yeah? Whereas with ceramic, it has to move into an area where there's no undercut. And you can see from that premolar that we had to extend the margin in order to get a solid contact with the tooth in front. And so all I literally did was I smoothed the mesial area of the canine, of the premolar, and then into proximally between the two premolars, I created a very, very, very small finish line for the lab for them to see where to finish the ceramic. So that was it. I mean, this preparation is done without local anesthetic. There's no temporization. Honestly, it couldn't be more simple. That's pretty clear, hey, John?
Perfect, yeah, no, perfect.
Yeah. So from there, I'm a big fan in digital dentistry. I think that if I look back at the benefits of digital impressions, there's unlimited number of things I could go into. But what I like from this slide where you see the colors, what it's telling me is that I can visualize where my finish line is on the occlusal surface of those premolars. And I can make sure that I have exactly the right thickness of ceramic to support the occlusal load that they're going to be under. And if not, all I need to do is reduce it ever so slightly and rescan that area. That's like, honestly, a 2-minute, 3-minute problem. And then in the middle, I think that, again, I'm a 3Shape user. I think there's lots of great intraoral scanning systems. I'm not sure how to sell them. But it also allows us to take a motion tracking scan to see, what are the areas of contact on other teeth and the guidance patterns. So yeah, I love the clearance, in all of my indirect, it just really lets me see that we have enough space, and space is always the issue, in my opinion, for indirect restoration.
No, completely. I love this view. It gives you such a clear idea of exactly where your contacts, future contacts, where your contacts are currently, and the impact of where your preparations need to be. So if you look at the left-hand side where you prepared on the premolar to convert it to a canal, you can see exactly where your finish line is going to go, and what you need to keep in mind when you start preparing and building that restoration. So to reduce the risk of breaking that mesial extension, because if you overload that, if that was a high contact area or contact with a huge amount of load, then you've got an increased risk of fracturing that piece off long term. So that just gives you all that internal information.
It's amazing.
Awesome.
It also shows me that I can also quickly reevaluate, look at the lower jaw, and make a quick adjustment to the lower jaw, and then rescan it. It'll show me the space. So I can make a decision in a case like this, that it doesn't necessarily mean I have to prepare to the upper teeth. I can go to the lower jaw and make a slight occlusal adjustment to get a better type of guidance pattern, because bear in mind we're changing one to the other.
No,
right.
Completely.
So after the 3D design is done, obviously we would have done the mock-up, and from there we then did the tooth preparation and then sent that to the lab for the final 3D printing working models for the injection molding process. So I think injection molding I was scared of at the beginning, because first of all, I think the biggest problem with injection molding is that if we're using wax ups, and I mean wax ups, I'm not talking digital wax ups, I think that it's very difficult to get that sort of accuracy that you need in order to transfer this into the mouth without ending up with a lot of excess, which means a lot of cleaning. And so, for me, it's about the precision of transferring the 3D design onto a model that I can then transfer back into the mouth. And so what we see on the left and the right is that, again, when it, in the early days of injection molding, we were trying to inject all the teeth at once and then try to separate them. And we realized that was impossible because the contacts got, filled with composite. We couldn't open them. And in all honesty, then placing freehand was a better option. But what we can see on the top is that the lab has the ability to design two models, one with alternate teeth and one with all of the teeth. And it's as simple as clicking a button. If you look at the video in the middle, you can see they can just, click a button on and off and it removes. So it's, this is really a simple process in a lab. If you're using wax, can you imagine how difficult this is for a technician? No, I think it's almost impossible.
No, that for me is probably the key to how you succeed in this job, or in this specific case, and how you went around that. For me, the biggest problem has always been transferring the wax into the mouth, and we've been doing transparent indexes and trying to copy
for
it
ages.
For good years. And the biggest issue is always is cleaning and the precision, and then the fit of that actual putty into the mouth. And if you start injecting and you do knit one, slip one, but you've got the whole, it's just a mess. You spend half the time cleaning up the one tooth.
Then it's not worth your while.
It becomes very difficult. And this is such a cool trick to just have the lab produce two separate printed models, and that's it. It's done.
Yeah. So just to fill you in on this case. So what we did, you'll see, is that actually we're doing the 4 anterior teeth.
Yeah.
First, we're going to do alternate. Second, we're going to do the other 2, in other words, to complete the 4 front teeth, which would have been turning the canines into a lateral and completing the centrals. But on this same model that we're seeing, we fabricated the 2 ceramic restorations. So this is the same working model that we're using to fabricate ceramic. So we've done 4 injection molding and then 2 ceramic on the left, 2 on the right. And so the reason that I did it like this, and maybe let's go to the next slide, is that when I seat the index, and John, you said it already, that the key to injection molding is the accuracy of first your design, your mock-up, your wax-up, or your 3D, and secondly, the accuracy of your stent, that they fit properly. If either of those 2 are wrong, don't attempt the case. In all honesty, that's my opinion.
That was always the biggest problem, is trying to copy.
Yeah. So anyway, we've generated now 2 models. As you can see, the first one on the left will be to place what's going to be the 2-1 and turn the 1-3 into a 1-2, and then the one on the right we're going to do second. So I've made an index, and you'll see we'll talk a little bit about the material, but you'll see on the bottom slides, you'll see 2 little black dots. And those 2 black dots are to remind me which teeth we're injecting. Because, you need to have a hold on that you place your holes in the right place. And we'll talk a little bit about that. So let me just go back to that. Let's mention, you'll see at the top of the slide here, I used Exoclear from GC. Clear silicon material, but there are a bunch on the market. Do you want to say something about that?
Yeah, so I actually had a good look around to try and find what is in the market. I think for us, currently the Exoclear from GC, Elite also make a Elite Transparent, which is also available. And then obviously the Clinician's Choice, which is probably, if I go back, 2012, 2013, the Crystal. So the Crystal came out originally when we started doing mock-ups. We used mock-ups with specific composite injected into the Crystal to do that kind of the show for the patient. And that's when this whole process started. So Crystal's probably been on the market the longest of the lot, and we've used it most extensively. Elite I haven't really worked with so much, but the GC Clear for me is probably the most transparent of everything. So it's definitely the clearest material, which is a bonus, because then when you actually work with it, you can see the composite as it starts filling in. It is so much clearer at what point you are within the filling of the material itself. So that works.
Let's move on, and when we've got a slide, we'll talk about that. So the next stage is obviously we've created the stent. I think the most important thing is, as John said, it's clear. So here it looks terrible because there are a lot of bubbles, but these bubbles are actually in the thickness of the stent. I've been very careful when I flow out of the gun onto the model that I don't trap any air bubbles. And when I have a look on the inside, if I see air bubbles, then for sure I'll redo it. So the next thing is we need to know which teeth we're injecting. That's why we did the black spots. And then we need to create the holes for the syringes, for the tips of our syringes. And so in a case like this, because we're filling the facial surface, the hole has to come out just in front of the incisal edge on the buccal side, as you can see. If it goes to the incisal edge, you're going to have a problem pushing the tip into this area, and in terms of allowing then the composite to flow from the gingival margin up. If you're doing, and I've done a few cases and I found out the hard way, so if you're doing a case where it's a full coverage situation, in other words, you're covering the facial and the palatal, then what you need to do is drill 2 holes. Because if you put your nozzle of your syringe in the front here, it's definitely not going to put any composite on the palatal surface. So I drill 2 holes. I drill one in the front, one at the back. And then I'm going to fill up the facial, I'm going to fill up the palatal, and then move to the next tooth. Okay, so we'll cover more we'll talk a little bit more about the technique, about how we do it, and John, you can obviously add up. As I say, it looks terrible. It looks like those bubbles, but those bubbles are trapped inside. Now, if you have it in your practice, or you can send it to a lab, you can put these things under pressure and you eliminate a vast majority of the bubbles. But the key is these bubbles are not sitting on the surface. So they don't really worry me that much. And I think the other key is that the index, and you'll agree with me, John, needs to be a certain thickness that it's rigid.
Yeah, the biggest problem we have is when you actually making the index, you want it to be rigid so that you don't get distortion when you place it into the mouth. But also you don't want it too thick, because then it takes too much energy for the light to get through to the actual material. Yeah. So there is kind of this Goldilocks thickness, unfortunately, which you get as you work with the material.
It's about 4 or 5 millimeters.
Yeah, but that varies ideal. From material to material as well, because each material's got a different thickness and strength. Somebody mentioned before that Mimosil from
Transil from Ivoclar. There's a bunch.
From Ivoclar, so there are quite a few different materials on the market.
But a lot of them are slightly opaque. Slightly opaque, which is a real, for me, a no-no. So, and the other thing from the slide, you'll see that I use a diamond burr. I don't use a carbide burr. If you use a carbide burr, it overheats and it starts to melt the material. So I've found by default the diamonds are really the way to go. That's what my wife tells me as well. So, so if we're talking about material, let's talk about what's available. We know that we're going to use a flowable material because it's an injectable case, but what are the essential criteria for this? And again, this is not a product-driven lecture. And I think there's lots of great materials or options on the market. I'm going to just tell you what I think you need to focus on, or you need to look at. So the first of all is strength and wear resistance of the material. I think that's standard for all our materials we use in the mouth. Rhodiopacity, opacity, I think that's something that are addressed nicely with most composites these days. Let's go on. That's not going. Let me just have a look here. Just have a look. Why is that not playing? There we go. Color options. We need to decide, has that material got the right color options for the case? I think that's really important. Color stability over a long period of time. I think we worried a lot of time about flowables because they were not color stable, but I think that the properties of these materials are very similar to the composites we're placing directly from syringes and compules. Shrinkage, I think that's obviously an issue. Extrusion pressure is really important. It's about that it doesn't come out too quickly, because if it comes out too quickly, it goes everywhere, or it doesn't come out, it doesn't come out enough. That's also because then you start putting pressure And once you start putting pressure, you might distort the index. And then, of course, ease of finishing and polishing. I mean, we want this to be cost-effective dentistry. We don't want to be sitting and hours finishing these things. And I think the reason I love this technique versus freehand is the ease of finishing and polishing is a fraction of the time, in my opinion. So in this case, I chose to use the Genial injectable, the universal from GC, only because I knew that it had good properties, and I've actually had been using it for other reasons, in my practice. So I was familiar with this material, but I think that there's lots of different options on the markets. So color is an issue. We have to really, like with any anterior restoration, understand the final color of what we're trying to achieve, and then choose the right material, whether it's indirect or direct. So and then we discussed this, that the difficulty on this case was that the restorations were going to be more or less the same thickness, but we had a big substrate problem, whereas one tooth was A2 and the other was A4. And I don't know if you want to say something there, John.
Yeah, the biggest issue always is trying to get the uniformity of the color. So the trick with working with composite or ceramics, of that matter, is trying to get the uniform color in the end, working from a background that is different shades and different textures. In this case, you're trying to go from an A4 and from an A2 base, trying to get the same end result. So it's important that when you look at that, you need to understand what the optic properties are of the material you're going to use. So you've used,
and we're aiming for A1, by the way.
We're looking for A1.
Yeah,
that's so how do you how do you convert an A4 into an A1 using a single shade in a single injection? And it's very difficult. It's difficult for a technician in a laboratory, whether you use Emax or any feldspathic. It's the same issue. It's how do you convert that? It's all about using the opacity of the material. So in this case, if you were to look at your options from GC,
Shall I go on?
You can go on. If you look at the options you have with GC, you have the traditional or your universal shade, so A1, A2, A3, and then you have your opacers. So an opaque, slightly brighter, A01, A02, A03. So in your case, what you'd look to do is try and use a more opaque material on the canine, which is going to allow that darkness of the chroma of the canine to be blocked out and still give you the same base. And then use a more translucent material on the central, where all you're trying to do is almost brighten up. And the more you add a little bit of a translucent material to it, the more you'll get that brightness or that change of the shade coming through. So the trick is using the opacity and the difference in the available to you in your material you've selected, where you've chosen GC, whatever other flowable composite you choose. It's just looking at the opacity that you can play with.
Yeah, no, that's cool. And listen, let's be honest. For me, I'm a big fan of universal composites. I mean, I so don't want to layer composites anymore if I can help it. For me, traditionally we went through so many years where we thought layering was like the way because it was like really cool. It was whatever. But, in all honesty, it's like really super complex, and it's super complex to always get the same color because, if suddenly the dentine layer is slightly different, everything changes.
It's so unpredictable. It's so difficult to work.
Yeah, it's like really technique sensitive, I have to say.
I love playing in layers only because the two things to that. The first thing is using a single shade is great if you're changing 4 or 6 teeth, because then you're almost creating the base platform. You can decide what you want it to be. If you're working with 1 or 2 teeth in an existing environment, then you still need to start playing with a little bit of opacity or the translucency to get the blend right. It doesn't have to be 100%. I think gone are the days where you try and get 100% duplication of tooth next door, because it is so technically difficult.
Yeah, no, it's impossible.
But it's so universal shades work for me when you're doing the whole thing. The other thing I like is just to have a little bit of depth to my restorations. So I like creating a little bit of, if I have a little bit of an enamel or a translucent shade over my single shade, it just creates a little bit of depth into the restoration. So it just almost brings it a little bit more alive. Well, I just find if you've got a single shade, only a single shade, and you start looking at it on photographs and you really look at it closely, then you can just find that it almost sometimes lacks that little bit of depth or creativity to it. That's the only reason I'd go back sometimes and give it a little bit of a once over with an enamel.
Yeah, so anyway, in this, we were fortunate enough that we had options of opacity and translucency. And so what I did is I realized that canine needed much more opaque material. So I opted for a dentine shade, as we can see, and an enamel shade, a universal shade. Sorry, that says enamel, but it's actually universal. I'm so sorry about that. But anyway, the beautiful thing about this technique is you get to see how it looks before you make anything. And actually, if you're anxious about color, don't forget you can injection mold 2 teeth without any bonding agent and then just remove it if you wanted to see that you had actually the desired, or that the patient was happy with the aesthetic outcome. So it's only when you put the bonding agent that these things are going to stay in place. So, you know, again, you can have the option of doing a try-in. And if you don't like it or something doesn't marry up, you can change it until you're happy with the color. Here we took a polarizing, cross-polarizing photograph, and I was happy that we were going to get, because I could block out the A4. So, you know, we're not going to talk really much about adhesion now, because I think that really it's a simple process, other than everything in my practice before bonding gets cleaned with air abrasion. I use AquaCare, 29 microns aluminum oxide. And I think today, again, most of us, if not all of us, are using universal bonding agents with selective etch protocols. In other words, etching all the enamel and using the adhesive, self-adhesive in the universal bond for the dentine. So I think let's not talk too much. Let's not talk too much on that. Let's get back to
that discussion's had, and that was had 2-3 years ago, and it's finished now.
Yeah, so again, we have some isolation. We're using an Optrogate on this. You can't use rubber dam in these cases, but let's also remember that once you put the index in, you're pretty much eliminating saliva from this case. So the key is, you know, first of all, you can see the 2 teeth that we're gonna build in mold is the 2-1 and the canine on the right side, which is the 2-3. So the other teeth that you don't want material, it's absolutely key. You cover them with Teflon, and then you go through the normal bonding process. So that Teflon covers 100% that tooth, so that nothing can get to it. And then we're going to put etch, our normal bonding agent. We're then going to take the index, which is appropriate. Make sure you've put them in the right order. You're going to put the index, which is appropriate for the alternative teeth. You're going to seat it, and then you're going to mold these teeth. So here's a key, that once you start this process, don't stop. Don't put one tooth, take it off, and then do the next tooth. Once this index goes on, you're going to mold as many teeth as you need to. So in this case, we were doing 4 teeth altogether, but you can do a full arch. But once you start removing it, you'll never get that index back in the same place. Yeah. So the key is you fill the tooth completely and then move to the next tooth. Don't remove, don't remove the index. Once you remove that index, it's over. And that's a really key factor. And then we're going to cure this, and we're going to remove it. So we've cured it here. You can see we've removed it. And look how beautifully it's transferred. All the information, the shape, the macro texture, even slightly micro texture on this case. And you'll see that actually I didn't really even realize when I was putting the slide, but I filled it. But we have a small air bubble on the 2-1, which is not a big deal because you're just going to take some of this material and fill it in. So at this point, we're going to remove the injection excess. We're going to clean interproximally. Okay, so we're going to remove the Teflon. We're going to clean any excess material at this point, because if you don't clean any excess at this point, the next index won't go on. That's a really important thing to realize. So we clean all the excess. It's super quick. I mean, look at the gingival margins here. Look how much excess I've really got. It's a really simple process. So we remove all the excess, we clean interproximally, and then we confirm the fit of the next matrix before we go on. So
yeah, that's very important. That everything as it checks as you go along. So you have to make sure that you clean the tooth completely before you go to the next matrix, and you have to check the matrix before you start injecting it. So 100%. It's always a check, because what you don't want is to prepare, start injecting, and you've got a misfit of your matrix, and you're back to where you start.
Well, you're just going to end up with composite in the wrong place, and you're going to have to remove it all.
No, exactly.
So yeah, that's super important that we have this sequence and that we don't. And you know, that's why I like Exoclear, because if you have these slightly opaque indexes, you really can't see that it's seated properly. You know, because you can't see the teeth underneath. So that's why, in my opinion, if you're going to use this technique, you have to use a material, an index silicon material that's completely transparent. It's not really to do with the curing. I think the light gets through all of these. It's more that I can see two things: that it's seated, and that when I've injected, that the composite is filled from the bottom all the way out. So that's really important. You know, so that really what we're trying to do is simplify the process. And what does simplify mean? It means, you know, actually having predictable buildups that, again, going back to that are facially driven, functionally driven, that we can transfer all that information into the mouth accurately, and then limit the amount of time that we have to spend cleaning the mess up. I mean, this is the win-win situation, in my opinion. So once you've injected that side, and you can see how beautifully that adapted. I mean, I think that, you know, this slide tells the whole story. Again, we've covered the composite buildups from the first index with Teflon, and we've built up the alternative teeth. And you can see the minimal amount of cleaning that I'm going to have to do in this case. So here we moved the injection excess. We cleaned interproximally. And then don't forget, this case, we're now going to fit the two ceramic restorations on each side. And so why did I do it in this order? Was because if I had fitted the ceramic first and created indexes over the ceramic, it just might have been that those veneers or those ceramic partial coverage restorations had seated slightly differently to the 3D design that they'd been created on, in which case the index wouldn't have gone down. So it was super important that I did the resin buildups first, and then the ceramic restorations were bonded. Yep.
No, completely.
Yeah. Right, let's crack on. So finishing protocols, you know, I think that finishing protocols vary from clinician to clinician. What I would say is that over the years, I've tried to simplify finishing. I've tried to find the most predictable finishing protocol that allow me to do it in the quickest way, but get the best result.
Yeah.
So a scalpel blade is my go-to first to remove excess, 12A scalpel. Then I'm going to use softless discs, maybe interproximally a little bit, depending where there's excess. I'm going to use Horico metal strips, but only the least abrasive one, the white one, because I don't want to open up contacts. This is more finishing at the gingival area, okay, rather than interproximally. I love the Epitex strips from GC. They're soft strips because they don't open up the contacts. But you know, here's another important issue, I think, for all composite restorations. You know, why do they often stain? Is A, because of bonding, and B, because they're not finished properly. Exactly. So it's super important to finish these things, because if you don't finish them interproximally so that they're super smooth, you're going to get staining. And so I think the longevity, the aesthetic longevity of the restorations is much better if you just spend a few extra minutes finishing. And then I love the Eve Dicom twist polishes because it's a two-step polishing. The first one, it's a kind of reddy color. Be careful, it's quite abrasive. We have to use it very gently, and then the gray one just finishes them exactly like this. And yeah, like what I want to just highlight, sorry, Jean, you can jump in a minute, is look, remember and I'll show you a slide of the pre-op, but look at the color integration, how we dealt with A4 to A1 on the canines, how we dealt with A2 to A1 on the centrals, and how the ceramic restorations also blend in so beautifully with all these materials.
Yeah, it's a great finish. Yeah. For me, the key is the use of a scalpel, the number 12A. That is my go-to all the time. That allows you to clean around the soft tissue interproximally, and also if you use a nice sharp blade, you can actually carve the material and manipulate and play with the marginal ridges as well, which is great. Just interesting for me. In this case, you're finishing with quite a high gloss, smooth surface. What would happen if you wanted to put a little bit more texture into the restoration? First of all, can you do that texture initially? In other words, in your wax up already. So can you build in the texture into your wax up?
100%.
Yeah, and then obviously, what is the alternative if you were to do it, build some texture in right now?
Yeah, listen, I think the beauty of this method is that what you see is what you get. You know, when you're doing this, if you're doing a case like this freehand and you did it 3 times, they would never be the same. If you're doing this case based on the digital design and I did it 3 times, I would get the same result 3 times in a row. And you know, that doesn't mean that my skill level has to change. It means, you know, in indirect restorations in the DSD community, we call it copy-paste dentistry. You know, this is what we're doing. We're copying and pasting a design that we've created from the digital mock-up. And yeah, you're right. Actually, we can incorporate the macro texture, the micro texture into the design so that when we transfer it, actually your polishing protocol even gets less. So you don't even have to think about how do I, as the dentist, create these natural shapes. You know, these natural shapes are created for us because, you know, in the digital workflow, we have beautiful algorithms which are already there, which are generated from what? Natural looking teeth. So, you know, this is why I get so excited about this sort of dentistry.
So basically, and the impression material we use that to make the stent, it's accurate enough to copy the design and the texture, margin ridges and everything that the technicians already created for you. So why not use that opportunity to just copy it across?
Absolutely. Yeah. So you know, this is taking dentistry, you know, you're kind of building up these beautiful things freehand was only for a few people. You know, this is dentistry we can all do, even on a bad day. This is what I love about it. You know, I mean, I really
Monday morning
get excited. Yeah, I really get excited about it. So if you look at the pre-op and you look at the shapes that we've created, you look at the color problems that we had, look at the functional issues we've dealt with, you know, by controlling the guidance. And more importantly, what is it? We've been super conservative. I honestly took a fraction of whatever the enamel was on the interproximal surface of the premolars, and that was it. The rest of it is an additive case. You know, we had complete clinical control. This is the key. And of course, in today's day and age, it's affordable. And, you know, you can take this whole concept and you can actually extrapolate it to full mouth, you know, opening vertical. There is really no limitation, you know, other than, you know, someone who understands about facially driven dentistry at the beginning and working with a good lab who can create the 3D designs that we need to generate the right indexes that, you know, that one thing leads to another. So the planning is key, but in my opinion, yeah, this is possible for everyone. And really what's more important than all the pictures, I know the intraoral pictures are super important for us, but for the patient, this is what he wants to look at. You know, this is what he wants to see. So what is it? It's facially driven, you know, facially driven dentistry. I mean, I think that is something that we've all come to expect, and affordable. So yeah, that's kind of, I believe, where we finished. Thanks so much for that, John, about that interaction. I think that there must be some questions, but first of all, just to remind everyone, and I can't see if there's anyone, to be honest with you.
There are a few people.
I trust there's some people who are
I know Howard's there.
Okay, Howie. So again, just to remind you, Implant Academy, Facebook. There's the Instagram to follow us, and there's the website. So that's where you'll find us. And yeah, I think that from here, we're going to go to some questions.
Yeah. While we're waiting for the questions, I just wanted to just reaffirm that this is still this is not just an idea that comes up from nowhere. If you look at the literature, there are a couple of people referring to research already done with this, and the ability of using flowable materials in this technique. I think the idea of a flowable, from 10 years ago is completely different to the flowable materials that we have today. That's key. In other words, these techniques are driven by the correct materials that we're using that are built and designed specifically for use like this. And then if you look at recent literature, if you know what's going on, just in March already, Quintessence published the indirect technique, where they speak specifically about combining the best of both worlds, that of the digital and the analog world, using techniques like this. And then I know recently also there is an article just for you, Mark, for interest's sake.
Yep.
They actually are now looking at how to print the silicon index. In other words, how can you create and mold the silicon index itself for the restoration? That was an article published in 2019.
Okay,
where they were looking at how you can, so you almost go from the digital design, and where you would then print a model. Instead of printing the model, you print the index.
Yeah, you print
and then
the
you use the index directly. So that would be the next step.
And your second index, or your last index, for where you've completed all the teeth, would actually serve as a mock-up.
Exactly.
I mean, again, I don't do any build-ups until I've done a mock-up. And here's the deal. Let's think about it. If you're doing freehand build-ups, how do you show that? Okay, you can do a mock-up. How do you show the patient what it's going to look like if you're building it freehand? You can show them a kind of what it might look like.
Yeah.
But that depends on what happens in the next 3 hours. Whereas with this, if you show them a mock-up, it's exactly what they're going to get.
Okay. Yeah.
Questions?
Yes, I'm looking at the questions here.
Yeah.
Okay, so there's one. There's a question there from Jean Stradom. To avoid air bubbles in the ExaClear when using old school WA, I use a thin layer of cold mold seal over the models. Also use a metal tray. So that's more a statement. Do you want to comment on that?
So if anyone's done my DSD course, they'll know that Shane from Diceray made me a whole lot of clear special trays that I use to make. And this is when we're talking about actually silicon indexes. We're not talking about clear silicon. But that clear tray is great because it's not a normal tray. Because if you use normal trays, what is the problem? It's perforated. So the material goes into the undercuts.
Yeah.
So I have a clear, it's like acrylic. And the spacer is about 4 or 5 millimeters.
Yeah.
You have to use something to seat it positively. You can't just syringe the material onto the teeth. That's not going to happen. So I syringe it, and then I apply pressure in a special tray, but it's clear and smooth. And so that if you use a normal tray, obviously what happens is the index goes into the undercut. So if you have a tray without undercut, that's awesome. Otherwise, get your lab to make you one.
Yeah, exactly. I think originally the clinician's choice clear material came with a set of clear hard trays, which you then inject into it. So you almost inject it into the tray and you inject it onto the model, and then you combine the two, and then you have the less bubbles. But obviously what Mark's using, that Shane creates for him, is much better, because it's actually something you can use consistently with different cases all the time. The other question, you just make a few. Just the blade that we used is a number 12. So it's a sickle blade, single cut. So it's a single cutting surface. You don't want to use a double cutting surface, because then you just cut the gum.
Yeah.
Which
to be honest with you, I use it double because I like pushing and pulling. There's some areas where, I think the important factor there, and if you start cutting lips, then go to the single side. But I like the double because I sometimes find that I need to push or pull. And so I like having both options. But the key is
I've just cut my finger too many times on a double.
The key is it's a number 12. That's
it's
the
a
only
number 12.
thing. Don't try.
Yeah,
you have to. That's the key. Any other questions?
Yes. We'll ask two more. We talk about affordability. What is the coding or something that we would use when you start doing these kind of things? How would you look at it from the patient, obviously from the clinician trying to get funding for this?
So I have to be honest, I'm the worst person to answer anything about codes because I have the most unbelievable treatment coordinator who sits with me and puts all the codes on. So I'm a little bit embarrassed here. But
I like that answer.
I think I would charge for a composite veneer or, or a 4-surface composite.
Yeah, it's a composite veneer.
Composite veneer.
Yeah, there's a code specifically for a composite veneer, yeah.
And remember that this can be done for a full mouth rehabilitation. So you would do the same thing with alternate teeth, going to your posterior teeth, which case you would use a composite onlay, I would imagine, as the code. I can't give the actual numbers, but that's what I would use.
That's fine. Then we have a question from earlier. Any benefit of using extra hole to serve as vents?
No, because really what you want is positive pressure. If you don't have positive pressure, then as you inject, then the air comes out the other one and the material doesn't go into the index. So you start with the tip kind of about 3 or 4 millimeters. You don't try and put the tip all the way to the bottom of the index because there's no space for the tip. Remember, as you go towards the gingival margin, like ceramic, the material is getting thinner and thinner. So you don't want to distort the index while you're syringing. So make sure that the index is secure, and then you want positive pressure, not a second. And then as you'll see the material go all the way down to the bottom. It's quite exciting the first time, I have to be honest. Not many things in dentistry excite me like this, but you'll see the material goes all the way down. And then as it fills, what I do is you just start to remove the tip of the syringe, and you'll see the material coming out. And then, the key thing about is curing. When you cure it, don't push on the index hard because you're going to distort the index. You have to, and support it on the teeth that you're not injecting. So it is really important that, but definitely not 2 vents.
And always
remember that.
You want the positive pressure. You actually want the excess material to come out to push your syringe out, force you out of the whole thing. That's the beauty about that.
And the other thing is obviously the hole that I've created in the index is slightly bigger than the syringe tip. So there's not pressure created inside there. That actually, if I have too much material, it can flow outside of the syringe.
Yeah.
But it's not going to flow interproximally. It's going to still come upwards.
Yeah. Because
that's the path. That's the path of. Yeah, it's a path of least resistance. That's the deal.
If it fits too snug, you can create air bubbles.
I can't stress the importance of the design. And how if you're doing this in wax, you can't. It's almost. Of course, you can do everything in wax, but once you start planning things digitally, you'll realize how much cleaner it is. And the most difficult place to clean is interproximally. The most difficult place to put wax is interproximally, but the most easy place to design is in between the teeth. So, really.
Digitally, that is,
it's a no-brainer. That's what's changed everything, and also being able to borrow these libraries of beautiful teeth. We use natural restorations. When we do this in DSD, we are actually taking people's teeth. Carry on.
That also then answers Herman van den Berg, who asked, how do you prevent bubbles? I think using a single injection, don't go out and back in again. Always inject until you can feel yourself coming out, and watch it as it fills in. That's important. And then how to clean the gingival area without creating too much excess bleeding. I think in that case, it's really about using your blades nice and conservatively. A nice, clean, sharp blade actually does a lot of that cleaning for you originally. And then any other flutes or any diamonds and things that you like to finish off with in the gingival area?
I find diamond if I have to, but I think that pretty much, again, we've said it so many times, the more accurate is your stent, and the less you have to clean. And so if you remember back to that one picture of when I took the index off, there was almost nothing to clean. Yeah, so that's why I love I love it. Yeah, that's the key.
Okay. I think that would be it. It's 3:15. Mark, if you want to finish off, have a closing, and then we can go.
Okay. Yeah. Thanks so much, John. Thanks so much, first of all, for everyone who was there. I didn't see anyone, but and happy Easter and happy whatever religious holiday. There's another holiday, I know. But I think that what we're trying to do is keep connected. We're trying to share stuff that's super relevant. We're trying to keep the excitement up about and passion up in our job, because I think it's missed a little bit. And so thank you so much, to everyone who's involved in putting this together, to Laura at the Academy. And we look forward to many more interesting cases like this one we've shared today. And so please also give feedback if there's something you might want to see or don't want to see, or, give us feedback, and we'll really try and deliver some quality stuff in the weeks going forwards and beyond, of course. That's the intention of the Implant Aesthetic Academy. So thanks, John. Thanks, everyone involved. Enjoy your weekend, and we will see you next week, I think, with Howie and myself. And
well
John
done,
and you and I.
It was a really great, well put together, short and sweet, no bullshit. So from both you guys, well done. Really appreciate it, and we'll see you again soon.
Thanks, Howard.
Cheers, guys.